Hi everyone, we're going to try to get through Chapter 19, Coping, Stress, and Tolerance, fairly quickly. So mental health begins at birth. Mental health promotion begins at birth with nurturing, having responsive caregivers, and continuing into the preschool and younger children's age group to help manage range of emotions. It's fostered through healthy family and peer relationships and is maximized through child and caregivers' emotional and social skills. The term mental health disorders describes conditions that affect behavior, emotion, and neurological development. A psychiatric illness and stress and altered coping skills can result from difficult life circumstances. Behavioral health issues include emotional health, substance abuse and use, and mental health disorders. There are many reasons for behavioral health issues in childhood and adolescence, including exposure to environmental toxins such as lead and mercury, genetic inheritance, caregiver neglect or abuse, and exposure to violence. Anxiety and depression can stem from genetic predispositions, neurohormonal influences, and the stress and strain of a modern family life. There's also increased evidence that suggests epigenetics, or the role of non-genetic influences, can be significant contributors to mental illness. And some of these epigenetic influences can include trauma, toxic stress, parenting styles, nutrition, hormones, social support drugs, and family interactions. Often many children with disorders can go unrecognized, and approximately half of those who meet diagnostic criteria do not get treatment. Some mental health influences that are mentioned in the book include fetal development. Mom's maternal nutrition and stress hormones can impact baby's development and impact mental health later. It is felt that there can be some protective effects based on nurturing that's received in the earlier years. Exposure to abuse and violence alters the white matter development in the brain, and then stress and environment deprivation can affect brain development. So when we're thinking about primary prevention of mental health problems, the first thing that we should think of is a positive, nurturing parent-child relationship. Kids need to experience the feeling of attachment and self-worth and being worthy of love. And this can serve as a foundation for developing social, emotional, and cognitive competence. Additional protective factors include supportive families, clear and behavioral standards, healthy peer relationships, high-quality schools, faith, sense of control over life, sense of purpose, and freedom from racism, sexism, discrimination, and poverty. Pediatric providers need to be consistently screening parents for depression at health visits, beginning with prenatal exams, because it's known that parental depression can threaten healthy parenting. Support by the pediatric provider can also help families to handle predictable life changes that can impact the child, such as daycare or school changes or moves. Increasing the parent or caregiver's awareness of developmental and temporal needs can help identify strategies that may be needed to help with transitions. Some secondary prevention or early detection helps address unanticipated life events. These can include social, emotional, or behavioral problems that may emerge even in the context of positive childbearing approaches. And so early recognition of these stressors is easier when caregivers have a realistic understanding of the child's development and possible developmental red flags. And then there's tertiary prevention, which addresses major loss and trauma. And this could include victimization through sexual and physical abuse, parental marital problems, divorce, substance abuse, or parental pathological condition. These would be some conditions where referral to a mental health specialist would be beneficial to the child. So let's talk a little bit about approaches to each developmental level of a child. The early childhood years are most critical for mental wellness. It's important for infants, toddlers, and preschoolers to have nurturing, supportive environments with opportunities for physical, emotional, and social well-being. Healthy attachment is critical to the development of healthy, happy, and self-confident kids. When kids are in these type of relationships, they develop confidence to explore the world and learn cognitive and social skills. With older kids, toddlers, and preschoolers, it's important to develop an emotional IQ. This can be achieved by allowing a child to express and recognize human emotion from good to bad and develop skills to cope with negative emotions. During this time, physical, emotional, and verbal abuse can be toxic to the child as they're trying to um, develop their self-identity and learn how to relate to others. So it's important for the provider to educate parents about strategies that can be when a child feels overwhelmed, how to communicate with their child in a developmentally appropriate manner. In the school age and adolescent child, we know that there's a lot of changes that can occur at home, at school, and with peers. Their self-concept and self-esteem face daily challenges in comparison to performances of peers in academic, sports, and social interaction. So it's very important to support them and be aware of their developmental level. It is a known risk that stress can impact and lead to mental illnesses. So it's important to allow older children and adolescents the opportunities for downtime and relaxation. Healthy parenting at this time could involve modeling and teaching healthy ways to deal with stress. Many children at this time are overscheduled with different activities, so it's important that parents are aware that kids need time to relax and mentally recharge from the stressors of school, work, and extracurricular activities. It's also important to be aware of high-risk behaviors such as sexual activity, alcohol or drug use, tobacco, aggression, and school absenteeism or failure. Let's talk a little bit about temperament and its influence on mental health. So temperament is an inborn characteristic that involves the individual style of emotion and behavioral response to situations. It's biologic in origin, but it can evolve and develop over time and can be influenced by those they're around and by social environment. In the book, in Table 19-2, there are a table with different type of temperaments and strategies to help with those. I would encourage you to review that. So as we're continuing to talk about temperament influences on mental health, temperament can be seen as a risk factor. Difficult temperaments are often associated with behavioral disorders, although a temperament alone is not a risk factor for maladjustment. Rather, these temperaments can exert an influence on the child's psychosocial adjustment by affecting their relationships. It's unrelated to their IQ, but it can affect their academic performance. So some temperament management could include recognizing qualities as temperament expressions, understanding how temperament relates to the behavior, and then develop temperament-based management strategies that will help deal with more challenging temperaments. These may be, applied to situations that may occur in toddlerhood, preschool, such as mealtime and bedtime, or school-related activities such as doing homework. In our assessment, it's important to note quality of exchanges between the children and the caregivers, whether that's parents, teachers, etc. Take time and listen. In infants, you may want to observe in a structured and unstructured environment. With toddlers, you're going to observe interactions with dolls, toys, and play that allows for spontaneous expression. In school-age kids, drawing pictures, having them tell stories will offer information, and in adolescents, it's important to interview separately. In the book, there are some sample questions that are that you might want to read over, that you can adapt to yourself, your own specific and personal questioning skills that you could use with adolescents. In your history, you're going to want to do a symptom analysis and assess for behavioral manifestations. You want to listen carefully to the parents' concerns and their observations. It's important to realize that a behavior that is a concern of a caregiver may be developmentally normal for the child, and offer education on that. If you have good communication with the caregiver and their concerns, then the provider can assess the parent's knowledge level about the child's development and behavior and can clarify which behaviors are developmentally normal, but that still may cause distress to the caregiver, and confirm which behaviors are outside of the normal range. It's also important to assess for any recent changes, any common family-related stressors, such as changes at family, work, or school. If there's been any changes within the family, separation or remarriage, any parental stress, any mental illness, impaired parenting, if there's been a mismatch between their parenting behaviors and the child's needs, any parent history of being parented, and any family health histories that could be pertinent. You're also wanting to learn more about prenatal and birth history, postnatal history, and any past medical history. You're exploring developmental issues, and you want to know their progress and daily living issues. You're wanting to know more about milestones, school, nutrition, sleep. You're going to be doing a physical exam and any diagnostic studies if you're concerned about any physical health issues that could be offering behavioral manifestations. You may consider behavioral or developmental screening and assessment tools if your findings are suspicious or ambiguous. This may be a time to refer to a mental health provider. The book mentions the tool, the Achenbach Child Behavior Checklist, as an excellent behavioral screen which has established reliability and validity and used successfully in a variety of clinic populations. So that may be something that you want to consider. It's available in both English and Spanish. And it has separate checklists for children ages 18 to 5 years old and 6 to 18 years old. Other screenings may include pediatric symptom checklist, maternal postpartum depression screening, a temperament assessment, and a behavioral diary. I think we all know that making mental health diagnoses can be difficult, and so it's important to decide whether the behaviors are within normal limits for the age, or there's other things contributing to it. Comorbidities can be common. In practice, several things that may be impacting the behavior include family, nutrition, sleep, and often mental health specialists such as clinical psychologists or psychiatrists may be required to assist in diagnostic decision making. In management strategies, we all know that mental health specialists are sometimes difficult to get our patients in with, and so assessing what the cause of the problem is will help you determine where it needs to be managed. So if the problem is a life event with acute short-term consequences, such as the death of a pet, a friend moving away, or a developmental something that's normal but a troublesome behavior such as temper tantrums, sibling rivalry, that's something that can be managed in the primary care setting. But maybe more difficult ongoing problems such as the loss of a parent, depression, may require collaboration and consultation with a mental health professional. So some common mental health problems may include the shy child. Shyness is a pattern of social inhibition with unfamiliar people, new objects, or unfamiliar situations. It usually diminishes by about school age. These kids may retreat or withdraw. They may be slow to initiate play or warm up. And when helping parents, it's important to provide strategies to provide warmth, sensitivity, and responsiveness to help the child to feel secure. Another common mental health problem could be bereavement, and this could, with grief, you may see distress, sorrow, or loss, and we know that it's the process of dealing with a loss of something that's important to the child. The clinical picture will depend on the developmental age of the child and their understanding of death, and so it's important, based on that information, to help the child resolve the effects of it at the appropriate developmental level. So with infants and toddlers, you may see them crying out, searching for the person that's been lost. You may notice sleep and feeding disturbances that will occur. They may appear sad or display regression. In preschool or older children, there may be shock or denial, which may lead to depressive symptoms and regression. Some concerning symptoms of bereavement may be long-term denial or avoidance of feelings, suicidal wishes or preoccupation with death, any distressing guilt or worthlessness, anger, decline in school performance, withdrawal, persistent sleep problems, or hallucinations. So when trying to manage bereavement with children, it's important that the caregiver understand what's going on for the child or adolescents with bereavement. There can be many questions, but equally as important is the child to participate in the rituals surrounding death as much as possible so that they understand the process. Kids need caregivers that help them to understand the facts of death and to correct any misunderstandings that they may have. There's many books out there that might help kids on the death and loss and grieving process. And it's important when there's been a loss that the child has someone that they can identify with as a resource that's going to offer support and involvement as well as focus reactions, help them to deal with reactions they may have to loss. Next, we're going to talk about fears and phobias. These are various avoidance responses to stimuli. They can also have apprehension in response to a situation. In infants, this could be a loss of support, such as physical support. If they are exposed to an unexpected stimuli, they may not like being in high situations. In preschoolers, they may have believe in imaginary creatures, be fearful of the dark, being alone. And in school-age kids, it can impact safety, and you can also see it with natural events such as school and any health fears. It's important to distinguish between developmental and abnormal fears. Most fears are short-lived and not serious, and avoiding using fears to control behaviors is important. There are numerous management strategies to help with fears for children older than 5, and these can include cognitive behavioral therapy and family interventions. And then also contingency management, and this is a therapeutic approach that's based on the idea that behavior is predictable in certain situations, and in those situations that positive reinforcement of the desired behavior may equal rewards such as hugs, attention, or praise. Another common mental health problem is anxiety, and this is defined as diffuse apprehension to less specific stimuli. This is a normal developmental phenomena that's experienced by everyone. We know that anxious responses include somatic symptoms based on our autonomic system, and these can include increased heart rate, blood pressure, tremor, sweating, enhanced vigilance and reactivity. But anxiety can also persist at high levels and can cause maladaptive behaviors that can lead to further exploration, diagnosis, and treatment. Anxiety can lead to generalized anxiety disorders, OCD, and PTSD. And some risk factors include genetics, temperament, and social environment. Let's talk briefly about separation anxiety. It's an abnormal reaction to separation, and it normally occurs about 7 months to preschool age. The child may cry persistently and cannot be comforted. Separation anxiety disorder can range anywhere from 5 to 16 years old, and it is a risk factor for panic disorders and depression, and it can evolve from poor attachment. So management of this condition, it's important for caregivers to learn how to help children identify feelings of anxiety by supporting them during exacerbations. Medications are not particularly helpful. Support is the key objective. With separation anxiety disorder, there's developmentally inappropriate anxiety. It's unrealistic. I believe we went over this. I was interrupted, sorry. Unrealistic worry about self-harm, reluctance to sleep away from home or alone, persistent avoidance of being alone, nightmares about separation, and there can be risk factors including treatment for separation anxiety needs to be approached as a family issue. Psychoeducation and parental education are important. In generalized anxiety disorders, it can be cognitive and obsessive in nature. The child can experience excessive anxiety, worry, and apprehension that can be generalized to a number of events and activities. They're considered worriers. Major symptoms can include worrying about future events, poor quality of sleep, being irritable, having tantrums, having an over-concern about competence and performances. They can be self-conscious and need reassurance, and there can be somatic complaints such as fatigue. Differential diagnoses can include separation anxiety, adjustment disorders, and ADHD, and management is going to include behavioral or family interventions, cognitive behavioral strategies, SSRIs, in older children. Treatment for these kids may include counseling to identify the source of anxiety. It may be individual or family. Treatments are more have positive outcomes when parents are involved in interventions that target familial processes. Let's talk a little bit about obsessive compulsive disorders. So we know that obsessions are recurrent thoughts, images, or impulses that are disturbing and difficult to get rid of. They often involve a sense of risk or fear of harm. The compulsive component is a repetitive behavior or mental acts that the child feels driven to perform, and that will help reduce anxiety associated with obsessions. These could be such as washing hands, objects, or body, counting, arranging objects. OCD differs from normal childhood behaviors as it's seen with marked stress. It's time consuming. In individuals, they may spend at least an hour of a day engaged in the behavior, and it interferes with the child's academic, social, and familial functions. They feel urgency or discomfort until the behavior is completed. They can have obsessive thoughts that are generally unrelated to events. There is a strong familial pattern and genetic link to obsessive compulsive disorders. There are some subgroups of patients with OCD, such as Tourette's, and there's a condition called PANDAS, which is an autoimmune response following group A beta hemolytic strep. And your clinical findings are going to be that you're seeing obsessions and compulsion. Differential diagnoses could include carbon monoxide poisoning, tumors, encephalitis, traumatic brain injury, Prader-Willi conditions, drug effects, and learning disorders. Management is going to be dependent on the degree of impairment. Cognitive behavioral therapy is best for long-term effectiveness and used as a first-line therapy. Pharmacologics for moderate to severe, and SSRIs are the best and the safest, and a referral to a mental health specialist if CBT fails or if symptoms become more severe may be warranted. Let's talk briefly about tic disorders. They're repetitive unconscious movements or vocalizations. It may be classified as Tourette syndrome if more than 1 year. In clinical findings, you may find simplex or complex motor tics. Common simple tics include blinking, twitching of hands or limbs, shoulder shrugging, tongue thrusting or squinting. Verbal tics include vocalizations or pushing air out through the nose. Symptoms may worsen during stress. And trichotillomania, which is pulling out eyelashes, I believe. I'm not going to look that up. Bruxisms or skin pulling or nail biting may be seen. Your differential diagnoses can overlap with ADHD, autism, OCD, seizures, and dyskinesias. Any diagnostic studies that you would do would be to rule out any organic causes. Management, if it's mild, no treatment. Moderate to severe would include cognitive behavioral therapy or psychotherapy, and then SSRIs, risperidone, clonidine, or anticonvulsants may be used for medication. Another common mental health problem would be PTSD, and it follows actual or threatened exposure to severe stresses or traumas. The criteria is witnessing or experiencing a traumatic event resulting in the risk of death or serious injury to self or others. Events resulted in fear, helplessness, recurrent distress seen in children, and you may see symptoms such as agitation or irritable behavior. You can have increased arousal, excessive startle or altered mood or emotional responses, and you can see recurrent dreams. And also there can be symptoms that last at least 1 month that can cause social impairment, cognitive impairment, or school functioning. And acute symptoms can be less than 3 months, and chronic symptoms can be greater than 3 months. There is a high rate of PTSD in kids that have been sexually or physically abused, and clinical findings when there's been repeated re-experiencing, such as recurrent or intrusive memories, nightmares, or distressing dreams. The distress can be caused by cues symbolizing the trauma. And then 3 symptoms not present prior to the trauma, reflecting avoidance of the trauma. So if you're seeing avoidance, efforts to avoid thoughts, amnesia of the trauma, detachment or estrangement, emotional constriction, diminished interest in activities, or a sense of foreshortened future. those can be 3 symptoms that are part of the clinical findings. The child may also show persistent symptoms of increased arousal, and these could include sleep disturbances, hypervigilance, difficulty concentrating, exaggerated startle, being agitated or disorganized behaviors, irritability, or an angry outburst. It's important with assessing that you provide a careful, direct interview to the patient or the caregivers to determine the traumatic event, the nature of the trauma, and if there's been any consequent symptoms of the trauma. Your differential diagnosis may include adjustment disorders, anxiety disorders, acute stress disorders, or OCD. Management, if there was concern for let me back up. So management is report to social services agencies if needed, referral to pediatric mental health specialist, and crisis interventions for the child or the family. Let's stop here with PTSD, and we'll come back with our next video to discuss depression. Thank you.